Hello again. Over the next 20 minutes, I'm going to talk about quality indicators in obstetric anesthesia. Here are my disclosures. Nothing is related to the content of this presentation. So here's the outline of my talk. First, I'm going to talk about what we mean by quality. Then I'm going to present the different quality metrics in obstetric anesthesia that have been proposed by various professional bodies. Going to spend a few minutes talking about balancing measures. And finally, I'm going to share some of the quality metrics for obstetric anesthesia that we use at our institution at Duke University. So quality indicators to assess healthcare structures, clinical processes, and patient experience and outcomes related to the provision of anesthesia are now a priority for many institutions in the US, in the UK, and many other countries. This was a systematic review that was published in 2018 that identified over 1,200 clinical indicators. Most of them were process indicators, 64%, but some were also structure indicators. The WHO has identified improving maternal health as a global key priority, and we as obstetric anesthesiologists have a key role in improving maternity care. But some questions that the subspecialty of obstetric anesthesia need to address include how to define and measure the quality of obstetric anesthesia care, what quality metrics can be used to benchmark and improve practice, and how routine data collection can be facilitated both locally and nationally to support benchmarking and QI efforts. So what is quality? Quality is an attribute that describes how good or bad something is measured against a standard. And in healthcare, it's defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes, and it is based on evidence-based professional knowledge and is critical for achieving universal health coverage. Peter Drucker, a renowned management consultant, said this famous quote, "What gets measured gets improved." And in the publication High Quality Care for All by the NHS, there is also a similar quote, "We can only be sure to improve what we actually can measure." The Institute of Medicine outlined the 6 domains of quality to be safety, effectiveness, patient centricity, timeliness, efficiency, and equitability. And these domains should be the framework for measuring our specialty's overall performance. So here are some examples of these domains as they relate to obstetric anesthesia. So for instance, for safety, we can measure the incidence of high spinal blocks. For effectiveness, we can measure the incidence of intraoperative pain during cesarean delivery. For patient centricity, an example would be patient-reported experience or outcomes. For efficiency, an example would be obstetric theater utilization for elective cesarean birth. For equity, a metric could be the accessibility of antenatal information to disadvantaged patients. And finally, for timeliness, an example would be the time taken to provide labor epidural analgesia after it has been requested by patients. The delivery of healthcare services can be evaluated through assessment of the Donabedian's triad of structure, process, and outcome. Structure describes the context in which care is delivered. An example would be the number of obstetric operating theaters, the number of obstetric anesthesiologists by shift, and the presence of high-risk clinic. Process denotes the transactions between patients and providers throughout the delivery of healthcare. An example would be neuraxial analgesia for cesarean delivery, time from request of epidural analgesia to its provision, and the use of multimodal analgesia for post-cesarean delivery analgesia. Finally, outcomes refer to the effects of healthcare on the health status of patients and populations. Example would be pain during cesarean birth, adequacy of labor analgesia, and patient satisfaction with obstetric anesthesia care. There are, however, some challenges as it relates to quality metrics in obstetric anesthesia. These metrics require resources for data collection. And since there is usually no imperative for local hospitals to report data nationally, there is little local support to facilitate either routine data collection or to make the data accessible to staff. There's also paucity of routinely collected data for QI efforts, and this is mainly due to the lack of evidence, of limited evidence on which metrics should be used, and therefore metrics are largely based on expert opinion, and there is paucity of patient-reported outcomes with specific patient-reported outcome measures for various health-related quality of life being not well established. So now I'm going to present you some quality metrics that have been suggested by a number of professional bodies. So the American Society of Anesthesiologists suggests 6 metrics: mode of anesthesia for cesarean delivery, Neuraxial-induced hypotension during cesarean, responsiveness to request for labor analgesia, opioid consumption post-cesarean, post-dural puncture headache accountability, and labor epidural replacement rate. And for each of these metrics, they provide this table that presents why they chose this metrics, some background literature, what is the best practice related to this metric. For instance, for mode of anesthesia for cesarean, they state that general anesthesia for cesarean delivery should be avoided when possible, but also initiated when indicated. And finally, they have a number of suggested metrics. For instance, for mode of anesthesia for cesarean, they suggest measuring the percentage of patients who receive general anesthesia for cesarean delivery, the percentage of patients who receive systemic analgesic or anesthetic adjuncts when cesarean delivery is performed under neuraxial anesthesia. They consider stratifying this according to the urgency of cesarean delivery. And then finally, they recommend considering making this metric as a process metric rather than an outcome metric, since each institution will have variability in obstetric practice, patient preferences, and anesthetic techniques depending on their patient population. The Royal College of Anesthetists has this obstetric practice chapter in their publication, Raising the Standards. It was published in 2020, and it proposes 90 different quality metrics and suggests some comparator standards. Here are some of suggested metrics. For instance, for accidental dural puncture, they suggest a standard of less than 1%. For reciting epidural catheters during labor, they suggest a standard of less than 15%. Adequate pain relief within 45 minutes after start of procedure, more than 88%. Response to request for epidural analgesia within 30 minutes. Patient satisfaction of labor analgesia, they suggest a standard of more than 98%. And decision to delivery for category 1 cesarean, 30 minutes, and for category 2 cesarean, 75 minutes. The Obstetric Anesthesia Association and the National Perinatal Epidemiology Unit collaborated on a Delphi project to create a core set of quality indicators for obstetric anesthesia in the UK. And the goal was to establish a consensus among various stakeholders on the most important and useful measures for assessing and improving the quality of care. So they started with a number of metrics, and through the Delphi project process, these were the final set of metrics: percentage of women with accidental dural puncture, guidelines for referral for antenatal and anesthetic consultation, the presence of elective cesarean section lists with dedicated staff, the availability of point-of-care testing for estimation of hemoglobin, and adequate pain relief within 45 minutes of labor epidural placement. You will notice that a high proportion of the quality indicators on this final core set were process indicators and not outcome measures. And the outcome measures were very limited. Additionally, the primary consideration in the consensus meeting was the measurability of the quality indicators. And as such, the process indicators predominated in the final core set. Also, the panel was predominantly composed of obstetric anesthesiologists, with only 10% of the stakeholders being service users, and therefore the final indicators should be considered physician and not patient-derived, which is similar to indicators or metrics suggested by other professional bodies. The Society of Obstetric Anesthesia and Perinatology, or SOAP, introduced the SOAP Center of Excellence designation in 2018 to recognize institutions and programs that demonstrate excellence in obstetric anesthesia care and to set a benchmark of expected care to improve standards nationally and internationally. So far, there are 90 US institutions and 14 international institutions that obtained the Center of Excellence designation. Duke is one of those institutions. And the Center of Excellence criteria were generated by expert consensus and incorporate evidence-based recommendations. This approach moves the focus away from creating a select few quality indicators towards a broad assessment of all aspects of obstetric anesthesia care, including personnel and staffing, equipment, protocols and policies, the presence of simulation and team training, how obstetric emergencies are managed, the management of labor analgesia on cesarean delivery, implementation of national and SOAP recommendations and guidelines, and finally, the presence of quality assurance and patient follow-up. However, this approach requires active application and peer review assessment and does not facilitate national benchmarking of quality standards for centers that choose not to apply or those who do not obtain the designation. So here are some of the metrics suggested or used in the SOAP Center of Excellence: general anesthesia for cesarean delivery, neuraxial, labor analgesia replacement rate, and inadvertent dural puncture. And you notice here some of the suggested metrics: less than 5% for GA for cesarean delivery, 3 to 6% for neuraxial labor analgesia replacement, and less than 2% for inadvertent dural puncture. And the important thing that the Center of Excellence Committee emphasizes and looks for is the presence of, ongoing quality assurance review for all of those metrics. The Institute for Health Improvement Model for Improvement is a frame for accelerating improvement work that involves answering three fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can be made that will result in an improvement? These questions guide teams in setting aims, defining measures, and developing changes, which are then tested and adapted through repeated PDSA cycles or plan, do, study, act cycles in order to achieve the desired outcomes. We've already covered the structure measures, the process measures, and the outcome measures, but now I want to spend a couple of minutes talking about balancing measures. Balancing measures are used to ensure that changes made to improve one part of the system don't negatively impact another part, and they offer a way to monitor unintended consequences of implementing quality metrics. For instance, when you look and measure GA rate for cesarean delivery, you don't want providers work hard to keep this rate low, therefore avoid indicated cesarean delivery, which will result in intraoperative pain. Also, by measuring epidural catheter replacement rates, you want to make sure that there is catheters that need to be replaced are accurately being replaced so that providers do not avoid replacements, which can result in suboptimal catheters that will not provide adequate labor analgesia and will not be adequate for cesarean delivery. Similarly, you want to make sure that there is no underreporting of inadvertent dural puncture. An example of this relates to the Ockenden review. The NHS used cesarean delivery rate as a key quality metrics. The Shrewsbury's and Telford Hospital boasted a cesarean delivery rate 10% below the national average. However, a series of safety events and complications sparked the Ockenden review, which found that 201 babies could have survived if the hospital had provided better care. And in other cases, mothers died and babies were left brain damaged. In this case, the metric was prioritized, and there was rigidity in keeping the cesarean delivery rate low, which led to avoidable harms. And subsequently, the NHS had discontinued using cesarean delivery rate as a quality metric. So finally, I'm going to share with you what we use at Duke for providing quality data for obstetric anesthesia. We use data for a number of sources. The first one is from MPOG, the Multi-Center Perioperative Outcomes Group, which is a nonprofit academic consortium that seeks to improve patient care using electronic health care data. It has 70 member hospitals. Duke is one of them, and there are some international sites as well. And you can see here the AUB is one of the international MPOG sites. So MPOG has a number of quality metrics for obstetric anesthesia, including antibiotic administration for cesarean delivery, spinal-induced hypotension, GA rate for cesarean delivery, and hypothermia in cesarean delivery. And for each of these metrics, each center gets their own data which shows their performance relative to the other MPOG centers, and also show them where they rank relative to the other MPOG centers. In addition to MPOG data, we measure the obstetric quality of recovery 10 score, which is a validated measure for assessing quality of recovery after cesarean delivery. And our nurses collect this from the patient's postpartum. We also have an obstetric anesthesia dashboard that gives us here, for instance, the volume of cases that we do, post-cesarean opioid consumption, epidural catheter replacement rates based on the type of neuraxial block, epidural, CSE, or DPE, and also based on whether this was a catheter used for labor analgesia that had a vaginal delivery, or labor analgesia that was followed by C-section or used only for C-section. And we also have information about inadvertent dural punctures and epidural blood patches and time from epidural request to provision of labor analgesia. We also have access to this dashboard that provides data on severe maternal morbidity in all our obstetric patients, and various dashboards based on QI efforts that we use. For instance, this is a dashboard for a task force that looks at improving efficiency in the obstetrics operating rooms. In addition of these data that are collected on a routine basis, we do ad hoc QI projects to address certain questions. For instance, here are a couple of examples. A few years ago, we changed the timing of administration of NSAIDs and acetaminophen. Previously, we used to initiate it in PACU, then we changed it to initiating them intraoperatively after we noticed a high rate of breakthrough pain in PACU, and we measured that, and we found that this change resulted in significant reduction in opioid consumption, especially in the first 2 hours. So we adopted this change in our practice. Another more recent one, we addressed a high rate of pruritus in our obstetric patient. We noticed that there was a high rate following the use of 150 micrograms of intrathecal morphine, which was our standard. So we did a QI project where we reduced the dose to 100 micrograms, and then we found that there was no change in the quality of analgesia, and no change in pain scores or opioid consumption, but a significant reduction in the need for antiemetics and antipruritics. So we adopted this change in our practice. So in summary, quality metrics offer a great way to analyze your current state and set goals. There are currently no gold standards, so you choose what is important to you and try to use routinely collected data for your QI efforts, which should be a continuous process. Thank you so much for your attention, and I look forward to your questions.